Today we talked about some of the exciting updates with melanoma abstracts over the last year. We reviewed first the Keynote 716 was in stage 2 melanomas and the adjuvant use of pembrolizumab versus placebo, and we saw that recurrence-free survival is improved for stage 2B and 2C melanomas to get adjuvant pembrolizumab. The other abstract we reviewed was the Relativity 047, which is the new use of the drug relatlimab plus nivolumab. The branded name is Opdualag versus compared to nivolumab alone. And we saw that with the combination drug, there was an improvement in the progression-free survival for patients when this was used in the metastatic setting or locally advanced setting as first-line therapy. The third abstract we looked at was the combination of nivolumab and ipilimumab used in the neoadjuvant setting for stage 3B and 3C melanomas. This is called the Prado study. This is an expansion of the PASSIN NEO study out of the Dutch group, and they found that the pathologic response was high when 2 cycles of Nivo plus Ipi were used 3 weeks apart, and then surgery was done. And they were also able to spare many people a complete therapeutic lymph node dissection when using the neoadjuvant therapy. Fourth abstract we talked about was DreamSeq, which was the sequencing of BRAF and MEK inhibitors, dabrafenib and trametinib, and nivolumab and ipilimumab in BRAF mutant metastatic melanoma. And the DreamSeq trial compared sequencing immunotherapy then targeted therapy versus targeted therapy then immunotherapy. And they found that the sequence of immunotherapy then targeted therapy led to superior overall survival at 2 years. And so this is confirms the sequencing for BRAF mutant melanomas. So I think the abstracts that we presented today over some of the key updates in melanoma over the last 12 months or so have really defined the treatment for first-line therapies in metastatic melanoma with BRAF mutations. It also highlights the use of a new adjuvant therapy for stage 2B and 2C melanomas, which is now FDA approved, and then also discusses the potential for neoadjuvant therapy in stage 3 melanomas to try to spare them from morbid and aggressive surgeries.